Here we go. Zoom. It should be starting. I think it's starting. I'm not really sure. I'm looking at my phone. I'm looking at the screen. I'm looking at my phone. I'm looking at the screen. Zoom. Done. Redirecting to Facebook Live. Hello. 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 Hi, OAC. So I'll just start with the intro if that's okay, Tracie.
Sure, go ahead.
We don't want to make people hang around with us. I mean, we want to get right to it. Okay, so here we go. Hello, Ontario Autism Coalition. My name is Karen Boite, and I am part of the OAC and a member of our board of directors. From time to time, we host Facebook Lives to discuss the issues that affect our community. Tonight, my willing victim is Tracie Lindblad. Hi, Tracie.
Hello.
Tracie and I serve on the board of the OAC together. And over the course of this coming year, I intend to bring you more board members from the OAC, whether they want to or not. They're coming on here and they're going to meet you. Tracie is a trained SLP, speech and language pathologist. That's what that stands for, yeah?
Correct.
Yeah, and a board certified behavior analyst, board certified behavior analyst. And she has a master's degree in education and something else, tiddlywinks.
No, that's a lot.
That's a lot. That's a lot. So I'm going to pick her brain tonight. These live conversations are an attempt, just an attempt, to unpack the issues that we discuss daily on our page. And we put it in a longer format than your average Facebook post, where Facebook posts back and forth with people in our community. So if you're watching live, please feel free to comment and we'll do our best to fold you into the conversation. There is a little bit of delay between Zoom and Facebook, so we'll try our best to juggle each medium. I've got my phone here and I will be looking and reading your comments as we go. Tonight, our theme, is everybody ready? Are you ready, Tracie?
I'm ready.
I'm just going to click on my Zoom here so I can see you live. I'm looking at myself on Facebook on a delay. All right, so tonight, our theme, in a system that forces parents to juggle between private and publicly funded therapies and education, how much, if any, collaboration happens between professionals? Can they knowingly or unknowingly work against one another? I have some pre-submitted questions from our community for you, Tracie, and a few of my own. Shall we start? Okay, so
Let's
Tracie,
go.
who the heck do you think you are?
Who do I think I am?
Who do you think you are, lady?
I know. I'm old. I'm old. I'm getting older every day.
Okay.
I'm someone who's worked in the field for a long, long time. Started out on one track as a speech and language pathologist. Loved working with children with ASD, and you got to think this is many moons ago, so there weren't that many around when I started out. Went through a few years as a speech pathologist, worked in the school system, hence the Masters of Education, to try and figure out that whole beast of a system. And then really started working privately with children with ASD and their families. And after a few years of being pretty anxious every single day that I wasn't doing enough, that I couldn't control behavior, that I didn't know how to help these families as much as I wanted to, that I didn't make the progress that I wanted to, sort of fell into the world of applied behavior analysis from two separate families who were bringing companies up from the US at that time. That was late 90s. And, you know, they dragged me along in their journey, and not willingly all the time, I'll be very honest. But I learned ABA, and the more I learned about it, the more that I saw it shaped my speech and language practices and my education life, and I got better results. I got better outcomes, and so decided to become a board certified behavior analyst. And by that time, the Ontario Autism Program had started. It was known as the AIP back then, and really started to get some good therapists and professionals in the province. So who am I? I'm someone who has a very broad scope of practice, meaning education, broad scope of competency, meaning I have different areas that I really concentrate on and work in and keep up the research. And I have many years. So I've learned the hard way sometimes, and to be where I am right now.
I wanted to talk to you, Tracie, because you have worn so many different hats. And when we do these Facebook Lives, I always remember how I felt when I was first figuring out services for my son. And I was so confused. And, for 7 years later, I'm still confused, to be honest with you. It's a journey. It's a process. But it takes a while to understand the different disciplines. So seeing as you can wear so many hats, can you break down your work for new parents who are still trying to figure things out? So how does the intervention, how do SLPs and BCBAs and educators approach their work from assessment to implementation? Can you break down those three different disciplines and how those pros
Yeah,
start their work?
sure. All three of those disciplines come from a very different theoretical background and viewpoint. So they're very different in how they approach deficits or disabilities or diagnoses. And then they're very different on how they approach assessment and then treatment. And so let's start with speech pathology, because that was the first one I did. So speech pathology is a medical model, and probably most familiar to people because they know about physicians and doctors and how that all works. People are very familiar with it. And so a medical model really does do an assessment of deficits or problems, comes out with numerous, so standardized assessments speech pathologists will give. If a child can't do a standardized assessment where they can get percentiles and scores and things like that, then they'll do an observation assessment. Sometimes speech pathologists do a diagnostic assessment in that they do therapy, and during therapy they try and test out some things. And so they'll come out with a list of areas that are delayed or disordered, that, you know, not just fit behind but different than typical children or neurotypical children. And then they will start to look at the child's developmental level, and what skills they can teach them. And there's a number of different approaches depending on the deficits or depending on the skill area. So for, you know, parent training, a speech pathologist will do parent training, and it looks much the same as a behavior analyst would do parent training. You want to coach the parent, you want to, you know, teach them things that will help them with their child, how to get your child more engaged, how to develop communication, how to reinforce those things. So it will look the very same as a behavior analyst. Where it starts to look a bit different is because of their education. Speech pathologists have a really wide wealth of knowledge in neuroanatomy, anatomy, physiology, child development, things that a behavior analyst and a teacher don't have, actually. And so the speech pathologist is invaluable for bringing that knowledge to the therapy and the treatment. So they know, you know, at a 12-month age, how many words should a child be saying? You know, how many sounds should they have? How intelligible should they be? How many words should they understand? What kind of eye contact, joint attention, pointing, all of that. They know that from all the child development literature. And so they will work from that and then build a child up, and look at it that way.
When a parent, but when a parent is just starting out with their little child, what does that look like when they walk into a speech path's office, and how does that assessment start to happen?
So typically, as in most, you know, medicals or medical professionals, they'll start by doing a background information. So asking the parent, how is the birth? What happened? You know, were there early signs? How was hearing? Have you had that assessed? Has your child been sick at all? Have they, you know, been in daycare with other children? Where have you seen the deficits? How is their eating? How is their sleeping? All those early developmental signs, they give you cues as to is the development happening at a pretty typical way, or is it disordered? Play skills, because play is the foundation of language development. So they'll ask a lot of questions, and then typically if a really young child, they'll spend some time with the child on the floor, engaging them. Like I said, providing or implementing standardized assessment, but it can often look like play. It often can look like, oh, we have a T set. You know, I'm going to do this and see if the child imitates you, see if they label things, see if they can pick up the things that you're talking about, give you eye contact, you know, let you know what they want or what they don't want. So they do a lot of assessment while they're with the child and look at it before they figure out, okay, this is what I think is going on. Often the speech pathologist is the first point of contact when a parent thinks there's something wrong. And I know that was one of the things that I struggled with being a speech pathologist, because I saw flags, those red flags for autism, and speech pathologists in Ontario cannot diagnose autism. We can't diagnose any disorder, not even speech and language disorders, if the parent may think that we're saying what a cause of that disorder is. We can say the child has behaviors consistent with an apraxia, or behaviors consistent with a speech sound disorder. But we can't say, oh, your child has ASD. What we have to say is, I see some red flags about language development or play, or lack of pointing, or lack of consistent response to name. You really do need to go see a developmental pediatrician or a psychologist and look at that further. In other parts of the world, almost anywhere else but Ontario, a speech pathologist can actually do that diagnosis. They're often part of a team, but it's in their scope of practice to be able to do that. We do not have that here in Ontario.
Yeah. I understand that speech pathologists have very strict rules of conduct and that they are a highly regulated profession. So are you allowed to suggest that a child is autistic? Give your opinion?
You're allowed to say that you see red flags, you're concerned about these areas. It can be consistent with autism. The difficulty, or the really hard thing about autism and autism spectrum disorder is that there are other medical disorders that can look like autism, but can be treated or need to be ruled out, because then you're dealing with something else completely. And so as a speech pathologist, we have no ability to order EEGs, or to order those genetic tests, or to order a sleep deprived EEG to rule out, you know, a different seizure disorder that can look like autism. And so, you know, I'm really thankful I actually don't have to make that diagnosis, because that's a lot on someone to take that on. But at the same time, we can say to a parent, look, I am seeing these things that are consistent with autism, but they're consistent with other disorders as well. You need to get further, you know, assessment of that.
So how do BCBAs approach working with a child to begin with?
So a BCBA, depending on the age and depending on the child, can often look very similar to a speech and language pathologist, but they look at more than, as a behavior analyst, there's not standardized assessments that we usually do. Maybe the Vineland, things like that, some parent reports that have been standardized, but it's really about, can the child demonstrate skills, and can they demonstrate skills under certain conditions? So you're always looking at the environment, you're watching if people are giving cues, you're watching what the child can do independently, and you're watching about, you know, how quickly can they do something, or are there barriers to the learning? So the one thing that behavior analysts look at really closely are, what are those interfering behaviors to that child learning in a more typical way? So if they prefer to, you know, be on the iPad and watch the same thing over and over and over again, and their attention is there, and you have a lot of trouble kind of getting their attention away from that, then that child's going to have a lot of trouble learning from their environment. And most of early childhood is actually learning from the cues in the environment you're in, and from your parents, and from siblings, or from daycare. And typical kids, you don't sit them down and say, okay, today we're going to work on, you know, big and little. They pick it up from their environment. But if your behavior is such that you're over focused on something else, or you're more interested in interacting with toys versus people, then you're not going to pick up the things that you need to develop properly.
Yeah, yeah. So educators, the child walks into the classroom,
Yeah.
JK has started. How do they approach their assessments?
So educators, again, do mainly checklists and standardized assessments. What you have to think about is when you go through teachers college or an education degree, you kind of start from a 4-year-old and go up. So a lot of our children that go to school at 4 years of age are functioning much lower than 4 years of age.
Mm-hmm.
And so teachers don't have that really early childhood development. They don't have that ability to know, oh, you know, they should be able to match on their own. They should be able to identify their letters and numbers. If they can't do that, they're not really well equipped to be able to teach that for a couple reasons. One, the curriculum doesn't have that in it. They go by a curriculum that starts at a certain point and goes up. And they don't have the time because now you're in a group-based learning. And so it's about having children and hoping as the teacher that they have the skills to sit, to listen to lots of language, to respond quickly, to wait their turn, you know, to know when I've said Jimmy versus everyone, and what does that mean? What is that difference? And so really it's so tough for educators when they can identify when a child is really struggling. They go into teaching for the same reason speech pathologists go into speech and behavior analysts go into ABA to help, right? To actually make everyone's life better. And it's really difficult in a classroom. And it's changed in 30 years. When I worked in classrooms, we didn't have very many children that had a lot of significant, you know, developmental problems or learning disabilities. It was, you know, in a school, I was lucky to have, when I worked in the school board, one child in a school that had an autism diagnosis. And now there's multiple children in every classroom.
Yeah.
And there's children with learning disabilities and children, you know, that have mental health issues at very young ages. And so teachers are trying to do group-based learning, get across a curriculum that they're having to deliver on a timeline, and still trying to do the best that they can to meet all the learning needs in their classroom.
You know, what popped into my head as you were describing like a junior kindergarten situation is a notion that most of us have when we have our babies and we have our kids, which is that, well, I need to socialize them. I need to get them with other children as quickly as possible. And I'm not seeing these markers happen. So if I could just get this kid in with other kids, then, oh, he'll learn or she'll learn.
Right. Yes, it's a nice wish. It's a good thought. In reality, it doesn't happen that way. And what we do know about child development is to learn from your environment, you need a number of prerequisite skills, of foundation skills. And so you need to really function around a 3-year-old level to be able to learn really well from a group-based situation. You need joint attention. You need to be able to sit and attend for long periods of time without being engaged, other than watching the teacher. You need to be able to listen to instructions given to a group and not given just to you one-to-one. You need to have imitation skills. So the whole basis of social skills and learning to be social is imitation. And so if you can't imitate, then you're not going to benefit from that environment. And that child then needs to be taught how to imitate and how the value of imitation. And so, you know, for lots of children that the thinking that inclusion concept seemed to be a good idea, except what we see is they're not going to progress without those foundation skills. So should classroom and should inclusion and should group-based learning be the goal? Absolutely, that is the goal. There's no way any profession or any combination of professions as a team can absolutely teach every single thing a child needs to learn in a one-to-one. There's just not enough hours in the day. It's exponential learning from like 4 months of age to 6, exponential. And so what you need to do is teach those skills that the child will begin to learn on their own. So they learn how to learn. is really what the kind of early game is.
Learning how to learn. Yeah, learning how to learn.
them.
I know that occupational therapy is not your wheelhouse, but a lot of people did ask me about that.
Mhm.
Could you describe what occupational therapists do, what their training is, and if you're able to, how do they first address working with kids?
Right. And I mean, I've been fortunate over the years to work with some really talented occupational therapists that were so helpful as part of our team and with the children that we work with. So occupational therapists are trained, my understanding, and it's really difficult. I still struggle a little bit, the difference between physiotherapy and occupational therapy. Because I mean, they all work with the same, muscles and person. So I still am not 100% clear, but I know for autism, it's mainly occupational therapy that work with kids with ASD. And they work with motor planning, of making sense of the world for children. If children have underreactivity to certain sensations or overreactivity to certain situations or sensations, trying to make sense of that sensory input for them. They're amazing when we're looking at how do we get better hand grip for eating, pencil grip for writing, riding a bike, walking up and down stairs, all of those movements that you need to do your occupation. And so that is really the basis of occupational therapy. Let's make sure you have those skills that you need, those movements that you need to be able to do all those other activities that you need in your life. Occupational therapy, the people that I've worked with are very much aligned in the way they work to behavior analysts, actually. They break things down into little wee steps. They master those steps before they make it more complex. Mm-hmm. And they just keep building on that. So, they align really well in a lot of ABA programs, occupational therapists.
Yes. I know that at my son's center, there are OTs all over the place, pre-COVID, but there were OTs all over the place working and consulting with the teams all the time. It's pretty cool. Mm-hmm. Can you define what the term core services means to you? It's a buzzword that the OAC uses. Oh no.
No, I mean, core services can mean different things, right? Yeah. So, and I think this came out of, and it depends where you are. It really does depend where you are and who you're talking about. So to me, core services means those fundamental areas that would impact the individual's life with the most significance. So if you have a child that has complex, their ASD, some people may say they have more needs, they're on the end of the spectrum that has more challenges, more needs. Then when you talk about core services, I would say, okay, their core deficits are communication, behavior, so the rigidity, the communication, requesting, understanding language, social skills will be in there. They may be having really a lot of sensory overload or issues taking in information. They may have eating difficulties. They may have sleeping difficulties. So for me, the core services then would be those professions that would remediate those areas or help with those areas. So that would be speech pathology, occupational therapy, applied behavior analysis, but it could also extend to psychology, because you've got children that have mental health issues, anxiety, which is not always in the scope of practice of any of the other ones. And then you as a core service too, you may, for some children, have to look at medical. There may be a seizure disorder and an underlying medical disorder that's really impacting how that child is functioning, or dietitian. So I think the OAP has defined it as certain professions. Mm-hmm. Mm-hmm. But that won't be the same definition that some parents will use. If you have a child on the higher end of the spectrum with less needs, maybe they only need a speech pathologist. Maybe they want social skills or pragmatics, or what we call, getting executive functioning. Maybe they need a psychologist or someone who's trained in cognitive behavior therapy. So those would be the core services for that child. But that would be very different than the one I just spoke to in the former. So the government has come up with core services and has named those core services for the purpose of that program. So I think that's what people have to understand. That's for the purpose of the OAP program. That wouldn't be the same as I would talk about them, if someone just came to see me privately and we weren't talking about a funding program.
Yeah. It's an important differentiation, I think, because most certainly the OAC, we will get accused of not being in the right fight. And what we'll often say, if people are willing to hear it, is that we are strategic. So we have a program that was not of our creation that we're fighting to save. And hopefully it will be improved. Hopefully smarter heads than ours will improve it.
Right.
But that's what we do. We are strategic fighters, and that term core service I think it means something different for everybody. I've got a question from Sophie. Actually, let me just rewind a little bit. So we've talked about a lot of professions: SLPs, BCBAs, OTs, psychologists you mentioned, dietitians you've mentioned, doctors you've mentioned. And I think there was another one. Oh, physical therapist. So there's a whole slew. Okay.
Yeah.
One of those professions is not regulated. That's a quiz. That's a trick question.
And your point is that
behavioral
aren't regulated, but what is your point about not being regulated?
Well, I want to know why. I've never been able to understand this. Why?
It's in the works. It takes a while. It takes 5 to 10 years for a profession to be regulated. It's not a quick thing. It's not an easy thing. It's expensive, for one. And you have to have a critical mass of people to regulate a profession because it is expensive to do it. And so I'm of the vintage that when I started speech pathology, speech pathologists were not regulated.
Oh, okay.
Oh yeah, that didn't come about until the late 80s.
Really?
And so, yeah.
Okay.
And so people think it has to do with, then you get, benefits and they're covered, and you're not covered if you're not regulated. That's not true. There's lots of, different professions that you've got extended health benefits and they weren't regulated professions. Social work is still not a regulated health profession in Ontario. It has a college, but it's not a regulated health profession. Acupuncture wasn't regulated till recently. Massage therapy wasn't regulated till recently, and people had benefits for those things. What regulation? And I remember when speech pathology was going through regulation, and it's an act. It's a government legislated act, and it requires really bright people with really good skills to get to define your profession and define your kind of swim lane that you're supposed to stay in, and what things you can't do, that to protect the public, because regulation is about protecting the public.
Yeah.
And so, and so for speech pathology, I think it took almost 10 years to get the regulation in. Behavior analysis is undergoing that process, but there's a lot of things that have to happen. And the government, MCCSS, has gone through some of those steps already, and they're continuing down the process. Behavior analysts have been asking for it. But again, if you think about, in Ontario, speech and language, the College of Speech and Language Pathologists and Audiologists, so that's 2 different professions under one college. There's about, and I don't know the latest, over 5,000 members. And we pay a lot of money a year. We pay hundreds and hundreds of dollars, almost $1,000 a year for our regulation. So there are only about 1,500 behavior analysts in Ontario right now. So when you look at the cost of having a college and having the legal people on there, people that work in the college, people that will handle complaints, all of that costs money. And so you have to have a large enough base of people to support that as well. Is it important? Absolutely. But it's only one piece of public protection, because within any profession, you're going to have people that don't follow rules, right? And so you, as a professional, you also have to be self-regulating. And so as a speech pathologist, I have to know you graduate with a scope of practice, which means your education. So I know I learned all these things in speech pathology school. And then when you get out, you start developing competency in things, because you have no competency when you graduate. You're your jack of all trades, master of none, newbie. And you're worried. Believe me, I can remember that first day of my job. I was shaking all the way.
It's an awesome responsibility.
Oh, it's imposter syndrome for years.
I'll
Really.
bet. I'll
For years.
bet. I'll bet. I
Yeah.
know that for like the level of trust that I have placed, that I've had no choice but to place in professional hands, and thank goodness most of the time I got lucky and found wonderful people. When that trust was broken or if that person wasn't effective, man, did things go south.
Yeah.
You know,
Yeah.
it's so important.
Yeah. And it's really important to be honest with yourself as a professional. And that's the hardest thing to say. Yeah, I don't really know what I'm doing. Like, I've only seen a couple of these kids.
Yeah.
Or I'm definitely not doing, like, I will not do a swallowing assessment. Did I take it in my master's? Yeah, but I have no competency in that. There's lots of risk of harm in that one,
Yeah.
you know, so I'm not handling it. And so that's the thing is for parents to start to understand that, you know, I think it's easier because the medical profession has these specialties that you can go and get extra training in. So you can become, you know, a surgeon, you can become a neurosurgeon, a hand surgeon, you can be, you know, as a dentist, you can go and you know, do orthodontics, you can, you know, practice and get really good in root canals. I don't know, lots of medical professions have these recognized specialties. Speech pathology does not. Applied behavior analysis does not. Teaching does a little bit in that, you know, you can get a extra training in special education or reading or science, but it leaves it up to the parent and the professional to be honest with each other about how can you help my child and how much do you know? And so really, you know, being regulated isn't going to help a parent. It's not that, you know, you and I are talking, it's not the good housekeeping stamp of approval that that person is great and there's going to be no issues.
Yeah.
It just means that they've passed the basic level to get that title and use that title, whether we're talking about teacher, speech pathology, occupational therapist, behavior analyst. It's an entry level to practice. And then from there, it's about being mentored and having enough experience and keeping up with the literature and getting colleagues, having mentorship, knowing who you can go to get that mentorship or to get your questions answered. Like, you know, and in some areas, the North, I know on the OAC, we talk about the North all the time. That it's hard when you're in rural areas and northern areas and that you don't have the choice that you do, you know?
That I'm keenly aware of that, because as the longer I stay in, the longer I observe and the more people I know, I see what a small family it really is, you know, and that services have been ostensibly eradicated. It doesn't just mean that the services are gone. It means that those partnerships are gone. Those relationships are gone. I have a question from Sophia. Sophia says, we've just started therapies for our toddler, but are now starting to find a lot of criticisms online from adults who have gone through ABA and IBI, saying that it can be abusive and traumatic. Can you please talk about how to qualify certain therapies? We've done that, and how to decide on therapists. Is ABA, IBI/IBI really harmful? And if so, why is it being recommended by as a gold standard of treatment by pediatricians? This woman has she let me know on another post that her pediatrician had recommended ABA, but she's nervous. So can you talk about abuse?
Yes.
Claims of abuse?
Yeah, I can talk about claims of abuse. That's a prominent, you know, that's prominent in the field right now, in the media. That is something that parents are hearing. That is something that some autistic adults, some autistic adults have claimed. What I can tell you is that we're talking for some people 20 years ago, 30 years ago, that they had ABA. ABA has been around for a long, long time as a profession. It's a scientific profession. It was it first was not applied to children with autism. It has its roots in regular education. It has its roots in, habit reversal, other areas, elite sports, training elite athletes.
I mean, things like Alcoholics Anonymous or
Yeah,
something like that.
addictions
Yeah.
is a big area. And so it wasn't until people, started to see children with autism and really try to figure out how to teach them best. And there wasn't great progress made by other areas. So education wasn't making great progress with these kids. The field of speech and language pathology wasn't. And so then the field of applied behavior analysis, which, kind of, some people think it's an offshoot of psychology. It's a completely separate field, but it is about the behavior analysis is about the science of teaching and learning. And it's really looking at how do I figure out how that child learns best. And so early on, there was a lot of punishment-based procedures in ABA. And people like to go back to Ivar Lovaas, who's like the father of ABA. He actually wasn't one of the first people, but people credit him a lot. And yes, he did use punishment, but corporal punishment was used by people for child rearing. Yes. Psychologists were proponents of it at the time. Yeah. So you can't take things out of context. At the time too, we did lobotomies in medicine. We used leeches. We did all kinds of things until we got better science to say, stop doing that. It's harmful.
Yeah.
Better ways of doing things. If you look at, Dr. Spock in child rearing, it was about let your kid cry, don't pick them up. They'll get and now we know that it was pretty harmful.
Yeah. Now that you mention it, Tracie, like I had not even thought of this before, but I'm 50. And I was never swatted by a teacher, but the old leather belt was hanging in the principal's office as a warning.
I had it.
So maybe you're slightly older than I am. I won't ask you how old you are, but I am 50, and I thought, it was we were spanked.
Yes.
We were, and So it hadn't even occurred to me. Like all kids were kind of bashed around all the time. A certain generation.
Punishment is actually effective. Not best. But it does change behavior.
Be careful. Yeah, it changes behavior, but it's not. Yeah, but it's
the best way to do it. That's what I'm saying. We've learned, right? We've learned. But what people don't do is say, don't ever go to a psychologist. Don't ever go to a physician because they said to use those things back then. Yes. Like fields change. And so I think what I would say to parents now is it is considered the gold standard for good reason, because it has so much research behind it and because it shows the most outcome in the least amount of time for your children. It is a life-changing therapy. And I was one of those speech pathologists really 25 years ago that was so anti-ABA until I actually learned it and until I actually saw what they do and how they do it and stopped listening to people and actually learned it for myself. Went out and investigated it and saw it and visited places and got trained in it. And then I'm like, okay, like this is different than what people are saying. I'm not saying they're not bad people. And especially in a field that's unregulated, you'll have a lot of people out there that have no education in it, do not keep up on the science, are not contemporary in how they do things. And yes, they can be harmful. Yeah, it can be dangerous. But just like if you went, for some treatment to Mexico, for stem cell injection, which is controversial right now and not lots of, research on it and not regulated, you're taking a chance by going to someone like that. So I guess the main message is go for it. That's why pediatricians are saying that, you should be getting ABA. There is lots of evidence that says that is one of the core treatments, the main treatments that you should be looking at, especially for children that have many, many challenges and don't have those foundation skills to easily sit and learn and are easier to work with and can't focus and don't look at you.
Yeah.
But do your due diligence with the people you're hiring or the people you're going to see, because it's up to you to make sure that they have the qualifications and have the experience. And it's well within every person's right. Every parent should be asking for the CV of the people they're working with.
Yeah.
As professionals, you are obligated to give that.
You know, one of the things I worry about, Tracie, is that we parents find ourselves in turf wars that are not of our making.
Yeah.
And I think a lot about whether or not we do harm to each other as parents. I'm very concerned about that. On our Facebook page, we give a lot of free advice to each other. And, you know, I think of it like, I know for myself, my son's SLP has been an incredible mentor for both of us. She's a very, very important person in my education and certainly my son's education. But in saying that, and with all of my loyalty and dare I say love for her, I don't know if I'm in danger of any kind of transference or any of that stuff, but I do love her. I do love her. It kind of feels to me sometimes like people will follow their therapist and all of their therapist's personal gripes and take them on. So for example, SLPs and OTs, they'll grumble about the fact that they don't feel that they can do their jobs properly because they're forced to work with kids in blocks, and therefore they have to be very, very strategic. So they might only get a kid for 4 weeks or 6 weeks or whatever it is, which is not even close to the amount of time that they require. Whereas kids who've received big chunks of funding can do ABA for months, maybe even years at a time. There's got to be some resentment, but I really worry about parents taking that on. It's not of our making, you know?
Yeah, and that's hard because there's systems, right? There's
Yeah.
systems that professionals work within, and those systems have limits. And as much as parents don't want to hear, that's not a human rights violation. Like that, any system is allowed to have caps, limits, say this is what we're going to do, say this is the program we're going to do, say we only are giving 8 sessions, we're only giving half-hour sessions. They can do whatever they want to do. They're a business and they have that right to do that. What makes it, for me, what I learned, and it takes a long time. And I think maybe the benefit of experience and years and age kind of, makes you more mellow in some areas, or maybe just gives you enough wisdom to let some things go that would have been a big deal when you were younger as a professional. But I know I used to be really upset about some of the things, like, why is someone going to the preschool speech and language program if they're only getting these blocks and then they're on an off block and you just wasted all this time and the child's not fixed? That speech problem is still there. But now I've learned it's like, okay, that's just a system. Like you can't spend your time and your emotion on that. That's not the right place to do it. What's better to do and is always be honest. As a professional, you always have to be honest with the parent. So it's not about saying this is all they need, which I think is what, even in the ABA and the OAP program, sometimes I think is where people struggled previously and where tempers flare up and people get these, staunch, no, it has to be this way. It's not about the look of the system or the program you're in. It's about the professional being honest with you and saying, look, your child has a severe speech sound disorder. I would recommend 2 hours a week or 3 40-minute appointments a week, because that's what the research says. If your child has a severe speech sound disorder, you should be having multiple appointments a week with a speech pathologist for a couple years to get this fixed. That's what we know. This program can do this. So you need to know that either you need to go out and get another private speech pathologist that we can collaborate and we can get more, or you're going to have to figure out how you're going to do that. Are we going to do some parent training so that you can become your child's therapist, whether that's good or bad? I mean, I do have problems with putting more onto parents, but sometimes just knowing that, that is what your child needs. But this program, whatever it is, preschool speech and language, OAP, whatever school, this is all we can do. But you're going to need more. So I think that being the professional and stating what is required, all professionals can't be afraid of that. Like even intensive ABA, we behavior analysts will do the intake assessment. We'll do our really detailed baseline of all these skills, like, 25 different areas that we're looking at, come up with this huge list and say, look, your child is, even though they're already 2 or only 2, they may be a year and a half behind skill development. So, I would recommend, let's start at 20 hours a week, 25 hours a week. Let's get to 30, 35 hours a week. The research says we need to do this for 2 to 3 years to get those skills up. And we're going to reassess every 6 months. But then, so, as a professional, you have to say that. If that's what the research shows and that's what your data is showing, you have to let the parent know, this is what I recommend. But then there's reality. So then the next conversation is, okay, so do you have the means to pay for this? This is what it's going to cost. Can you get funding? Does this fit with your family? Are you able to do this as a family? And all of those factors become part of the decision about what services fit. And it's at the time, because what we do also know is it changes as the child goes along in their development. So what you need at that point in time may be something completely different 2 to 3 years from then.
Well, it can be very crushing. We did a Facebook Live a couple of years ago, or I did, and I interviewed my child's clinician and the supervisor at his program. And this was just before the big announcement and we knew it was coming, where we didn't know it was actually going to be quite that bad, but we had a very strong feeling that the program was going to be blown to smithereens. And that's what happened. And there was this panic in the OAC, which is, how do we inform new parents about what has been lost, what has potentially been lost? And so I asked the clinician, so I gave an example. It was actually, I think, the day after the announcement, and was, okay, so if you have, and I gave him a pretty serious scenario. Like, you've got a kid with pica, a child that is consuming and eating items that are not food, who is smearing poops, who is not toilet training, who is banging their head 67 times a day, hard on the floor, you name it. And things that in our circle, and I see you nodding, it's not such an unusual thing. And I know there may be some parents who are a bit shocked by that, but in our world, this is not so unusual. And I asked him, I said, okay, so at that time, the announcement was that kids under a certain age would receive $20,000 a year, and other kids would get $5,000 a year, and therapy for full-time therapy costs up to $80,000, right? So we wanted to give this urgency to the community. Like, look, if you have this kid, you have to step up. As exhausted as you are, as freaked out as you are, you've got to step up. And going back to my son's SLP, she said, well, congratulations, Karen. So because I, as a SLP, I am given a finite amount of time. And if I was to say to a parent, it's all over because you can't have this full-time program, what am I doing to that human being? What am I doing to that parent? So how do you gauge that? If you have a child and this kid needs to be in an intensive program for their health and safety, much less good manners and happy stimming and all that, and getting along with friends in the kindergarten. We're talking about kids that need an immediate intervention, and there is zero funds for that child. What are you going to do, Miss Smarty Pants, with your 3 degrees?
I mean, that's where it's so difficult, because as a professional, I know the research. I read the research. I've seen it in the province for 20 years. I've seen kids that were in that, and it's really 40 to 50% of the spectrum that are on that end. And a large percentage of those children could be like that, because still 30 to 50% of children with ASD don't develop really good spoken language. They don't have good communication. In the absence of communication, you get behavior. You get problem behavior. It's the only, we all resort to problem behavior when we can't get our message across. And so I know, I know all the research. I've seen it myself in doing therapy and working with kids for 30 years. I know what that intensive service can do for a child. I know what it can do for the family. I know what it can do long-term. And the difficulty becomes, if we don't have that, like now, then it will actually impact all of society, because it now means that they haven't learned the skills that they could have to be as independent as possible, to go through life with more skills, to not get to adulthood when you go off that cliff. And all the parents know that now you're going to have to try and, parents have major mental health issues as your child ages and doesn't have good skills. They get beat up. You see these, you're starting to see more on Facebook where parents say, this is my reality.
Yeah.
It is rampant. There is
Yes.
a large percentage like that.
Yeah.
And it's really hard.
And it's such an act of desperation to expose your life in that way. To me, that's a real sign of that there are no doors to open for these families.
No, I know. And I can tell you from the therapist,
yeah,
it is so much easier to work with a little wee one who hasn't kind of learned all these compensatory behaviors that are not good adaptive skills. They're going to, be barriers to them. It's really easy to work with them when they're little and prevent all that. But I have clients that are, in their 20s, 30s, 40s that have 3 and 4 to 1 therapists. They're harming themselves. They can't be out in public. They're incarcerated. Our prison system has got so many individuals, adults that are incarcerated that probably are on the spectrum. We know they are, not probably, we know they are. And, that's what we're trying to do. I think especially the OAC, take what we know about services and research and treatment and therapy, get it in as early as we can, because we know that that's better long-term for everybody, for that child, the family, but also for society. Because, there is not enough money to when you start getting to adults and all the other things that are happening in our world. And so it's that whole pay now or pay later. And it's hard for parents, because I was a parent of 2 little kids, and I remember my grandmother used to always say, oh, small children, small problems, big children, big problems. And I'm like, oh, what are you talking about, Grandma? Right?
Yeah, I know.
And then it happens to you. And then you go, whoa.
Ooh,
I'm glad I was a bit more naive when I was, a younger parent, because wow, I didn't know what was in store for me. And my life, like my children are neurotypical, so I don't have, what a lot of the parents are dealing with that are part of the OAC. Definitely don't have that. And so I can't, honestly, I can't imagine. I mean, I have good friends, I've stayed with them that have children that are complex and severe, and I'm exhausted after a couple of days. It's tough. And I was just gonna say, I don't have the answer. I don't know how we show them and not be, because I have been called out and saying you're gaslighting families. You're gaslighting people. You're making no, it's because I can see it. I have seen it, and they don't know where we're headed.
Yeah.
And it's,
I feel you there. I'm a newbie, relatively speaking, to you, and I'm only a mom, but I'm able to slowly pull my lens back, and see where we started versus where we're at. And in that process of being mentored, my confidence has grown, my ability to adapt has gotten better and faster. But it's the result of my son being under such competent care.
Mm-hmm. Mm-hmm.
and entrusting the process, and also with the providers that I worked with, making very good judgment calls on how much I could handle, and making very good decisions on what they were going to throw my way and what they were going to protect me from, you know, as we try to open my child's world to be larger and larger and larger and larger. I had no idea how slow and methodical that work truly is. I had no idea. Okay, so I wanna move into how professionals can work together and complement one another. Okay, so I found an article that you wrote in 2011. I'm going to quote you. Okay.
Yep.
All right. So this is for the Canadian Association of Speech and Language Pathologists and Audiologists. Did I say that right?
Yes. Yep.
Okay.
SLP, which
Here
is
we go.
SAC, but okay.
So there's a lot of big words in this, Tracie. You're going to have to help me, okay? The dissemination of behavioral research related to speech and language and communication is at the grassroots level, arising from clinicians in practice, and is yet to be adopted within the university training programs.
Right. Oh, I don't even remember writing that, but 2011. So I was a pretty new behavior analyst back then. Yeah. I mean, wow. Okay, good.
Surprise! Surprise! So
what it means is that, oddly enough, the field of speech pathology got its start in behavior analysis. So it was behavior modification was the root of speech pathology in the 70s and 80s. And then it took this real divergent path away from that. And
was that your time, Tracie? Did you start in the 70s?
No, I started in the 80s.
In the 80s, okay.
But so when I did speech pathology, it was still very much more, it looked more like behavior analysis. It was very much, we had small goals. We knew how to operationally write goals. In fact, I practiced that. We measured, we took data. It was very much aligned with a more behavior analytic practice. And then I think after that, it changed a little bit. And I know even today that in some programs there, the value of taking data and knowing how to write really strong goals and measuring them well is still not really there. And that was part of that, I think, quote was that there is good behavioral research in the same areas that speech and language pathologists practice in. So there's an overlap of areas that we treat, just like there's an overlap with speech pathology and occupational therapy and swallowing. So swallowing disorders are handled by both professions. Both professions are trained in it. Many areas of a child with ASD, many of the areas and deficit areas have overlap with education, with teachers, with psychology, speech pathology, occupational therapy, and behavior analysis. And so this overlapping scope of practice is there, but what hasn't happened, and not yet, like 10 years later, is that the behavioral research that's in behavior journals. So there's like, if you say to a speech pathologist, who is more trained, better equipped to handle requesting behavior? So a speech pathologist will call it requests, behavior analysts will call it mands. Who has more research, who's better equipped? Speech pathologists, hands down, will always say them. They're wrong, unfortunately.
Uh-oh.
They have way less research to back what they do than behavior analysis in that area. But the problem is neither field reads the other's literature. And it's not that speech pathologists don't know what they're doing. They just don't have the same amount of research behind it. They don't have alternatives. So if it doesn't go well, they don't have as many alternatives that they're well versed in that behavior analysts have, because there's been so much more research done in that. And so I think that's part of it, that there's some real wealth of information from the field of behavior analysis that could actually strengthen the practice of speech and language therapy and therapists. Not that you don't need speech pathologists, because they possess a whole other skill set with child development and, like I said, the physiology and all of that behavior analysts don't have. But at the same time, the techniques or the technology of how do you do something well, the how you do it absolutely, behavior analysis is phenomenal at that.
Mm-hmm.
Way more systematic, way more accurate about measuring. Oh, you were still using prompts. Oh, they don't have that independently yet. That is where the marriage between the two works really well. So you get the speech pathologist helping with, okay, a typical child needs to know how to do this.
Mm-hmm.
You know, so this is good vocabulary, or this type of sentence structure we're going to work on, or these speech sounds. But the behavior analyst can really help say, okay, this is how to do it, and this is how we're measuring it, and I can, you know, help you analyze the data.
Mm-hmm.
And so they work well together, but it's just at its infancy still.
You know, one of the things that I think parents get, I can say for myself, and I think I can safely speak for a lot of parents, is there's a big separation of church and state, you know, with all of these services. And Laura talks about this in terms of politics. She talks about the silos, you know, so there's the Ontario Autism Program is funded by this ministry, and then medical services are funded by, you know, other ministries. And so, and we are, and then of course there's the Ministry of Education, right? So everybody's got a different boss, everybody's got a different regulatory body,
Mhm.
and there are turf wars. They just do exist. We're on the receiving end. So for somebody, a professional, maybe it's a gripe they have, you know, during coffee, but for us it spills out into our freaking lives, right?
Yeah.
So what do parents do if, for example, there's an ABA center that won't consult with their speech and language pathologist or their OT, you know, and there are schools that won't allow their ABA therapists into the school? Like, we can't transfer, the teachers are not talking to all the teams. So we end up being quarterbacks on these teams with these teams of people, if we're lucky,
Mhm.
who don't talk to each other, and
Mhm.
somehow the parent have to be their own care coordinator, to use a term, to make all of these things work. What's the beef? Like, why is this so?
I mean, it's so, number one, historically, because
Yeah,
interprofessional practice, like being a real team, an integrated team, is pretty new. You know, there's not a lot of research that actually shows outcomes when you use integrated teams because it's so expensive.
yeah.
So if you think about it, you're double paying everyone to meet, right? So you've got a number of professionals sitting at a table, and you know, you can go around and add up the cost of that in terms of hard money costs, but also time.
Mm-hmm.
And then you have people that still aren't really familiar with each other's background and training, and their views are different. They come at it from a different lens all the time, which, when it works well, works really well. Because
Mm-hmm.
if you're confident in your skills, and you have respect of the people you're working with, you have really great discussions, and you can really, you know, do some out of the box thinking, which is what you need to do sometimes. So the integration and having a single goal that someone takes responsibility for, but takes in all those other scopes of competence from all the other professions,
Mm-hmm.
works best. But it's not easy. It's a really difficult. And you know, and a lot of the places don't allow for it. Like, there's just no time for it. And
Yeah.
so in schools, there is no time for a speech pathologist to sit down with teachers and the special ed person. Like, they're trying to get their own jobs done. Not that that's the way it should be, just that is the way it is.
Mm-hmm.
Often, even in big agencies, the speech department is separate from the ABA department. Look, we have McMaster University. This is one of my new pet projects, my idea. McMaster University has a ABA undergraduate program there. They have a
Yeah.
speech pathology graduate program. They have an occupational therapy graduate program. They have a
Yeah.
medical program. They don't talk to each other.
Mm-hmm.
They still
Mm-hmm.
don't have an integrated program for
Yeah.
ASD, right?
Yeah.
So it's like, it has to start kind of in your training. And it is. Graduate programs are starting to do this interprofessional practice and get students, while they're young, and students start working together with, you know, for a number of disabilities
Yeah.
and disorders. But it's really tough. And I think the toughest is it's hard for parents to get conflicting information because they
Yeah.
don't know how to figure it out then.
That's right. So what does a parent do? What does a parent do if sometimes it's just the vocabulary, if you ask
Mhm.
me, and I'm not intimidated. I've got a dictionary, I'll look it up. But what do we do? Really, our heads are spinning. If we're dealing with kids with very high needs, we're getting conflicting information. The professionals either can't or don't wish to talk to each other.
Yeah.
We're trying to develop trusting relationships with and get good guidance. You know,
I mean,
this is
it's hard.
frankly, Tracie, this is a mess.
I know it is a mess. It is a mess.
This is a mess for families.
Yeah. And the only thing really that a parent can do as much as they can is try to see which professional or which person, whether it's because of a relationship or because of how they're doing therapy or treating your child, which one is making the best progress, which one is getting your child closer to where you want them to be. I mean, and that's all you're going to be able to do. And as a professional, I'm telling you, I mean, I can freely admit now, again, I'm saying maybe it's because of the age. I was one of those professionals that say, no, I know that you shouldn't be doing that. I know this is right, but I know that was right because I've done this for a long, long time and seen thousands of children and can see the difference in different therapies. I've worked in an interdisciplinary, multidisciplinary places for a long time and know education, speech, and ABA myself. But I think sort of I look at it different now. I actually, in some respects, don't really care what people are proposing to do, as long as the professionals that are involved agree to take data. As long as they agree to abide by evidence-based practices, which is a process, which is what all of us should be doing, where all of our professions say you have to abide by evidence-based practice. And evidence-based practice doesn't mean that treatment has the gold stamp of approval. It means that what you're doing, that you have done a number of things for all professions. It means that you have assessed and you've identified goals. It means that you've talked to the family about their wishes and you consider what they want and what they can do. You've gone to the literature, you've gone to research, hard, well-designed research to show that there's support for what you want to do. Because every professional is obligated to use the best research, but there isn't research sometimes. So you have to say, okay, then clinically, I'm recommending this. And that's the clinical judgment is where different professions will disagree. But then as long as you say, okay, the goal is, I don't know, let's say the goal is we want this child to be able to request for their favorite thing because we want the tantrums to reduce, which is a really socially significant goal. Then you can say, okay, the behavior analyst says, I want to do it this way. The speech pathologist says, I want to do it this way. I don't know. So then it's like, okay, can we all agree that's the goal? Perfect. Let's agree how we're going to measure it. So we're going to count number of words or we're going to count, decrease in tantrums. And then it's less important really how we get there as long as we're all taking data. Because if we're taking data, then we can come back with no emotion and no ownership and ego and say, let's look at the data. And if the data is going up, I don't really care then who kind of won that one.
Yeah.
But we all have to agree if the data isn't going up, we have to change.
Try another way.
We have to try another
way. This conversation went in a different direction than I anticipated, and I'm delighted because talking to you is a big treat. Really, it's like free therapy for me. But let's close off with some really practical ways to help the parents out there. And I don't mean specific advice about their kid. And by the way, everyone, I have been reading your comments and I'm going to tag some people on them after the chat that may be able to answer your political questions, like if you have a bad ABA provider, what do we do about them and things like that? Because poor Tracie doesn't need that. Didn't need that shit, but we, the OAC, we deal with that. So a mom, a dad, head is spinning.
Yeah.
Okay. Nothing's going right. school is a disaster, can't afford therapy, or they can afford teeny, teeny, teeny little bits of therapy, and they can't afford to make a bad choice.
Right.
Right? That is where we're at, where people are right on a cliff's edge, and we have families in states of desperation that I wouldn't wish on my worst enemy. You know, this is a big shitstorm that we're in right now. Okay. Hey, hi
Yeah.
everybody. Yeah. Okay. So for the freaked out parent, the isolated parent, what's the best way for a parent to present their child to you so you can use your time most effectively? What kind of information do you need from that
Right.
parent, and what kind of relationship do you need to develop with that parent?
So you need, the information you need is what are the few things, 3 or 4 things that would make that parent's life, that family's life better in that moment. So in the moment, what is the most pressing thing? Because often what I'll get from a parent for the very first visit is, will my child talk?
Right.
Well, the whole thing about getting a child to talk, we're talking years often. We're not talking immediately. But I can say immediately, why do you want your child to talk? Well, because I don't know what they want and all I have is behavior. Okay, then we can work on that. There's lots we can do for that immediately.
Yeah.
You know, and there's parent mediated interventions that are really good at that. And so I think the other thing that I want to know is, how much are you as the parent, how much are you able to do? And be realistic. I mean, that's what I keep saying to parents. When I give you some goals, don't just say yes because I'm saying you need to work on all these things, because I've been there as a parent. I've been there when my kids came home with stuff from school and I couldn't get to it. I couldn't do it. And so it's better to be realistic and honest. There are so many things going on with parents. And I can tell you, I was one of those really not nice speech pathologists before I had children. Like, I would be that parent that speech pathologist said, oh,
Yeah.
you came in again and you didn't get the homework done from last week. Like,
Yeah. Can I interrupt you? Can I interrupt you?
yeah.
Therapists, don't do that.
No,
Okay?
don't do that.
Don't do that. Just don't. All right,
Yeah.
go ahead, Tracie.
You have to know what it's like to be a parent. You have to be in those shoes before you can be very realistic. And so so it's be honest and not punishing to the parent. Like, just be honest. Like, everyone has stuff to deal with. You don't know what else they're dealing with in their lives. And especially in autism. We have parents from the very first minute those kids are diagnosed that are thinking, and they say it quickly. A, will they talk? B, what happens when I'm gone?
Yeah.
Those are the 2 big questions.
Yeah. How can you
And-
possibly focus on anything when you've got that big?
Yeah. And
When
so
you're
it's right. And so it's about distilling it down to now. Let's focus on now. What are those things we can work on now? What is this step, this first step we're taking? And then, what's the next step? And I'll have parents say, I want this goal. And it's like, perfect. That's a great goal. But here are the 10 things that first we have to learn before we get to that goal. And so I think you need to help them with the plan. And they need a plan, a short-term plan, short-term goals, and then see where you're going with that plan. Because it's hard. Like, that's why we go to doctors and we say, like, this is wrong. What do I do next? And you listen to your doctor. And I think that's, on the OAC, as helpful as parents think they are, as a professional, I can tell you, and all my colleagues, it's really hard for us to read all of those personal opinions that you think you're helping your fellow parents because it worked for you and for your child. But that's the thing, it worked for you and your child, but that doesn't mean that the other children are the same as your child or their family. And you have to be very careful that what you're saying isn't negating maybe a major problem that's there in the background that you need a medical person or a professional to actually have eyes on, because it isn't going to be the same as your child. And there's a lot of fad stuff going around. I think the other thing that I would say to parents is, go to someone who isn't here. Go to someone who's not invested and no conflict of interest. go to the Association for Science and Autism Treatment website, go to the National Autism Society website, go to websites to see what are all the treatments, OT, SLP, ABA, that have evidence, that actually have empirical support, research behind them, and make decisions based on that.
Yeah.
Because it's going to be better.
We grapple with this at the OAC all the time. And I know certainly Laura and myself have had dozens of conversations, which is that she and I remember very clearly our early years, the feelings of isolation and not knowing where to go, not knowing what to do. And social media is one way that people reach out. That being said, we are a political organization. We're political advocates. So if you want to find out from us what's the best way to sit down with your MPP, we're the people to ask.
Yeah.
If you want to sit down and say, my kid needs an EA, gosh darn it, in their classroom, or a one-to-one, how do I make that happen? We can't do it for you, but we're the people to ask. We're the people to ask in terms of how you go up the chain of command, how you navigate, how you negotiate. In terms of what you think is best for your child, we have no place in making any kind of recommendation like that. But it's tricky. It's tricky, you know? So
And
I really,
And Karen, I think it's that way too, because professionals are we're trained. We have oaths that we take in ethics that we actually can give you a lot of information about your child from a description. We actually have to go through that process of assessment, seeing the child, doing the assessment, and going through those steps. And so I think sometimes because parents aren't getting hard answers from professionals online, they turn to each other. But it doesn't mean that that's the better thing to do.
Yeah. But what is not part of the conversation when we're giving each other all this free advice is how much this stuff costs.
Yeah.
So an assessment, just quickly, because we've hit our time, but as a BCBA, the assessment process, approximately how long does that take?
Oh, again, it depends on the child. It depends on the age of the child, depends on what their behavior is like, but you're looking at upwards of, without a report, probably 5 hours at the minimum to do a really thorough assessment of all the baseline skills, sitting down with parents. And then it can take upwards of 15, 20 hours for some children, because you can't just go at an assessment with a child who's not used to listening to instructions or has, attention span is very limited. So you're looking at thousands of dollars for most assessments, like even speech and language therapy. Like if you're going to do communication assessments or, receptive language, expressive language, and you're going to look at play skills and social skills, you're looking at a few hours at upwards of $200 an hour. And so they are all expensive. OT too, all master's level people are roughly in the same range of cost. So you're looking at, between $120 to $200 an hour.
Yep.
And
so
and
from the OAC's point of view, when we say to families, well, you get your $5,000 and you can take your shopping cart and you can go through the mall and pick a little bit of this and pick a little bit of that. Is that potentially harmful for kids who are severely affected by their autism?
Yes. I don't know how to say it more plainly. That is harmful. In fact, there is research that shows it's called eclectic treatments in the research, or multidisciplinary. So where everyone has their own goals. So you go and get, speech pathology for a little bit, and the speech path is working on X. You go to OT and you get this, and they're working on Y. You go to ABA and they're working on this, and you might go to psychology, and you've got all these things. Then they actually can be working at cross purposes and making your child worse, not better. And we see that all the time. And I know it's this feeling like I have to get more because more is better. And I can't afford, intensive ABA. So I'm just going to get a little bit. And the speech pathologist can only, do an hour a week. So I'm going to take that too. And that's not what we know about ASD. What we do know is that you need to even out skill development for that learning to learn to happen best. You need to have really consistent consolidated goals where everyone's using the same approach, because these kids learn, but sometimes they learn the wrong thing if you're not aware of what you're doing, or if someone's doing it one way and you're doing it another. And so it's really important. And I know as this is not going to be what parents want to hear, but if I only had $5,000 and I had a child on the spectrum that was like mild, not moderate to what those labels, moderate to severe, what we mean is more needs to a lot of needs, then I would spend my $5,000 getting a really good interdisciplinary assessment, meaning go to a place that has the OT, the speech, and the ABA that all assess together, write their report together, and give you your plan for the future. Because then you can take that plan, and no matter where you go, you can say, look, the speech pathologist was on this plan, the OT and the behavior analyst, and they're saying my child needs this. And then you have your plan. Unfortunately, right now in the province, there's so little money that it makes it really difficult for all but the mildest of children right now to get what they need, which is the really sad thing.
So the OAC would say, you take that plan and then you fight, fight, fight.
Yes.
You fight for a needs-based service, needs-based system.
Yes.
Yeah?
Yep.
Tracie, thank you so much.
You're welcome.
Thank you so much. I have a feeling people would like to hear from you again sometime down the road. Do you think we could have another chat?
Yeah.
Just, you know,
Hey,
we're just shooting the breeze. Like, what do you got to do?
That's right. No one's going anywhere.
Yeah. Okay. Tracie, thank you so much for your time, and thank you for helping me through my nerves. I know I was punching above my head.
Oh.
I know I was punching above my weight tonight, and I hope this was helpful for parents and helpful maybe even also for other therapists who are working with us. We love our therapists, we love our teams, and we want kids who need these folks to have them. That's what the OAC is about. That's why we're all here together. So Tracie, thank you. Thank you for joining our board and being such a great counselor and a helper to us. And till next time.
Okay.
I'll see you at the meeting on Sunday.
Yes. Yep. For a few hours.
Good night, everybody. Thank you so much. And I will have a look at the comments and see if I can tag people to help you out. Thank you. Good night. Good night, Tracie. Thank you.
Good night.